Good morning everyone. Myself Dr. Namita Gupta. I am Associate Professor, Department of Palliative Medicine. Today we are reading Opioids and Non-Opioids in Cancer Pain Management. Pain prevalence range from 33% in cancer patient after curative treatment, 59% in patient on anti-cancer treatment, and 64% in patient with metastatic advanced or terminal phase. Opioids are widely used for cancer pain because they have safety, their multiple routes of administration, their ease of titration, their reliability, and their effectiveness for all type of pain, especially in the cancer pain. This is the WHO analgesic letter we have to read in for the pain management. This is step 1. It is for non-opioid analgesic as NSAID. For the step 1 pain, we can give NSAIDs or non-opioid analgesic. For the step 2 pain, we can give weak opioids like tramadol. And for the step 3 pain, we can give strong opioids, oral administration of fentanyl, of morphine or buprenorphine, or we can give transdermal patch also of fentanyl and buprenorphine also. And for the step 1, 2 and 3, there is a non-surgical treatment, and for the step 4, we have to give neurolytic block therapy, spinal stimulator, we have to give surgical treatment. WHO analgesic letter may have many limitations in the context of long-term survival and increased disease complexity. Then the type of cancer pain. Acute pain is severe and lasts for a short time, and the chronic pain or persistent pain, it lasts for a longer period of time, as the name suggests, longer than 3 months. Chronic pain doesn't go away, but it can usually be controlled by the pain medication. It is not controlled, it is not cured, but it can be controlled by the pain medication. And the last one is breakthrough pain. Breakthrough pain is a flare of pain that happen even though the patient is taking pain medicine regularly for the chronic pain. We are giving morphine sustained release tablet, 30 mg in the morning, 30 mg in the evening. But when the patient has breakthrough pain in the evening, so we are prescribing 10 mg or 20 mg morphine extra for this breakthrough pain. Okay, so we have to consider this breakthrough pain also, otherwise the patient pain will not be controlled. The underlying pathophysiology of pain: direct tumor invasion by the local tissue, metastatic bone pain, osteoporotic pain, and degenerative joint pain in the older people. Many are pathophysiology. We have to read this later on. What cause of pain in people with cancer? Pain from the cancer itself. Pain from the cancer can be caused by tumor pressing on the bone, nerves or body organ, by the spinal cord compression, by the bone pain, or pain from the cancer treatment also, by the procedure and testing, by surgical pain, phantom pain, and side effect of chemotherapy. We are giving treatment to the cancer patient. Side effect of the chemotherapy and radiation treatment, peripheral neuropathy, mucositis, radiation necrosis. This cancer has been cured, but when the patient is receiving chemotherapy or the radiation treatment, is also having severe pain. So we have to consider this pain also. So the principle of pain management. The main principle of pain management, including the use of biopsychosocial approach, should be applied rather than simply following the WHO letter. A patient is coming up to us for a severe pain. It is not required that we have to give pain medication as a WHO letter as a step 1 medication. We can direct jump on the morphine. So we have to consider the biopsychosocial approach also, not only by the WHO letter. That's why we have to give by step 1, step 2 and step 3, then step 4. No, we can also jump in the step 3 as a first time. Mechanism-based strategy incorporating the recent scientific discovery of molecular and cellular changes in the chronic and cancer pain. Care of patients suffering from cancer pain require a holistic approach, combining psychosocial, social, rehabilitation and pain management. Guideline for the assessment of patient with the cancer pain. We have to assess and reassess the pain. We have to assess and reassess the patient, and we have to assess and reassess the ability to inform and to communicate with the patient and the family. The pain, patient and family. Now opioid. These are strong opioid: alfentanil, fentanyl, mepridine, methadone, morphine. These are strong opioid. These are the low opioid: codeine and proxyfen or tramadol, etc. These are mixed agonists and antagonists or partial agonists, buprenorphine, butorphanol, nalbuphine, and other antagonists are naloxone. This is a morphine, as the names I told you, this is a strong opioid. Drug for severe cancer pain on the third step of WHO analgesic ladder. In the first step, we have to give non-opioid, non-steroidal anti-inflammatory drug. In the step 2, we are giving weak opioid. In the step 3, we are giving morphine. So this is the drug for severe cancer pain and for the third step. Morphine has a short half-life. It is primarily metabolized in the liver and its metabolites are excreted by the kidney. Morphine 6-glucuronide contribute to analgesic activity, and 3-glucuronide may be the cause of some of the side effect. Fentanyl. Fentanyl is a highly lipophilic opioid. It can be used intravenous, epidural, intrathecal, transmucosal and transdermal patch are available. And the transdermal patch have an advantage that the risk of constipation is very much reduced when we are giving transdermal formation. So this transdermal formation is very safe and the maximum risk of fentanyl are eliminated by the transdermal preparation. It has a rapid onset of action and short duration of action. It has more analgesic potency 100 times than the morphine. Fentanyl may be preferred over morphine in patients with kidney insufficiency because of this active metabolite are not there. As we have read, morphine have metabolite M36 and M6 also. So fentanyl doesn't have these active metabolite. It can be so it doesn't cause kidney insufficiency. Then is a table of opioid comparison. This is the fentanyl. Its onset is less than 1 minute, peak action in 5 minutes, duration is 0.5 to 1 hour, and intravenous equianalgesic dose to morphine 10 mg IV, we have to give only 0.1 mg more fentanyl. For 10 mg morphine, we are giving 0.1 mg fentanyl. Okay? Yeah, we are giving 100 microgram of fentanyl. This is the morphine. Onset time is 5 minutes, peak is 20 minutes, duration in 4 hours, and protein binding is 30%. Another opioid, sufentanil and remifentanil. Sufentanil onset is less than 1 minute as remifentanil, both having almost same action, and their dose are very much less as compared to morphine or as compared to fentanyl. 0.01 milligram is given as compared to 10 milligram of morphine. As I have told you, route of opioid administration, oral. Morphine have oral tablet, buprenorphine oral tablet, sublingual and buccal, rectal preparation of tramadol, subcutaneous preparation, intramuscular, intravenous, transdermal preparation of fentanyl and buprenorphine are there. Intraspinal, we are giving fentanyl, buprenorphine, morphine and many more opioids by the epidural and intrathecal route and by the patient-controlled analgesia. As I told you, for mild to moderate pain, weak opioids such as codeine, tramadol and dihydrocodeine should be given in combination with non-opioid analgesia. The opioid of first choice for moderate to severe cancer pain is our oral morphine. The average relative potency ratio of oral to IV morphine is between 1:2 or 1:3. We have to assume that patient is taking 60 milligram morphine as an oral tablet. When we have to give intravenous preparation of this morphine, this is reduced to 20 milligram. So it is 1/3 of the oral morphine. IV preparation have potency. IV preparation has to give 1/3 of the oral. Same is with the oral to subcute morphine. Transdermal fentanyl and transdermal buprenorphine are the best reserve for patient whose opioid requirements are stable. In the presence of kidney impairment, all opioids should be used with the cautious and at the reduced dose and frequency. Fentanyl and buprenorphine by the transdermal route or by the IV are the safest opioid of choice in patients with chronic kidney disease of stage 4 and 5. Opioid for the breakthrough pain. Immediate release formulation of opioid must be used to treat exacerbation of controlled background pain. Immediate release oral morphine is appropriate to treat predictable episode of breakthrough pain when administered at least 20 minutes before such potential pain trigger. So when we are prescribing 60 milligram oral morphine to a patient, 30 milligram in the morning, 30 milligram in the evening, we have to prescribe 10 mg morphine for this breakthrough pain. So the breakthrough dose is 10 to 20% of the total daily dose. When a medicine doesn't give the pain relief, doctor may prescribe a higher dose. okay, or take it more often when we are giving, okay, when we are giving 60 milligram morphine 20 20 20, okay, and generally morphine is given as a QID 6 times a day. So 60 milligram of morphine is a given 10 10 10 10 4 hourly 10 milligram of morphine. If patient is complaining, okay, I have pain relief for 2 hours only, but for the rest 2 hours I may be in the severe pain and I have to take oral morphine after 4 hours over. So we have to increase the dose. We have to give 20 milligram morphine for this 6 hourly for 20 20 20 20, or we have to give 15 milligram morphine. So we have to adjust our dose according to the pain of the patient. It dose doesn't remain same for the lifelong. If the patient is complaining of pain, then we have to increase or decrease the dose of the drug. If pain relief isn't last for longer enough, then extended release medication can control the pain for the longer period of time. And for the breakthrough pain, a fast acting medicine or immediate release opioid will give fast pain relief. So sustained release means that the drug will be released under first order kinetics. Therefore, if a drug start out at 100 milligram and release at a rate of 10% per unit time, so 72.9 milligram dose is sufficient. And for the controlled release means that the drug will be released under zero order kinetic 10 milligram per unit time. So it is given as a dose of 70 milligram. Then the adverse effect of opioid common are constipation, dry mouth, nausea, vomiting. Uncommon are bad dreams, dysphoria, myoclonus, pruritus, respiratory depression, urinary retention, and opioid-induced hyperalgesia. We are covering our management of opioid side effect in the next class. Okay class, then you have to prepare for this side effect of opioid. Thank you.